we'll go through it again. So MCTAC is a training, consultation, education resource center that is providing resources to mental health and substance abuse disorder providers in New York State. And the goal of MCTAC, especially at this point, is to prepare and assist providers with the transition to Medicaid managed care, which we are officially very much underway with. MCTAC is a collaboration between the McSilver Institute for Poverty Policy and Research at NYU and the Center on Alcoholism and Substance Abuse at Columbia University. MCTAC does not work alone. MCTAC works with some partners, including CCSI, NIAPers, IDEAS, and us, ICL. We're going to pause for a couple of seconds to allow the people who are on the call to complete the survey. So I'm just going to pause for a couple of seconds. So you should be doing your survey now. You see that there are 3 questions on the side. I feel comfortable, I can't see that far. I feel comfortable explaining what managed care is to clients. I feel confident explaining HCBS services to clients, and I feel comfortable speaking with clients about the possibility that services could be limited. So these are all things that we're hoping to tackle today during this presentation, and they're things that you should be thinking about actively. I'm going to give another minute or so. And we're still here. I'm going to be your... So we're going to be asking these same questions at the very end, and we encourage you to stay on long enough to complete those questions at the end so that will help us measure if we've accomplished any of our goals. Okay? So we're going to get started now. Oops, sorry, forgot again. My name is Naomi Weinstein. I'm the Vice President of Innovation here at ICL. Sorry about that. So we are now in topic 5 in our series on utilization management. We've talked about case conceptualization, treatment planning, supervision, documentation, and now client education, always from the perspective of utilization management. After today, we have one more session on family engagement, and that will be next Tuesday, January 12th. And just to note that unlike previous webinars on this topic, there will not be an applied learning discussion on January 19th. Okay? And we also would ask you to complete the evaluation at the end so that we know how to improve this series for the future. Okay? So let's dig in. So first of all, whether or not your program has made it a point to talk with clients about the changes, chances are they've heard something about it, right? Especially in New York City. They may have received a letter from the state, and if so, if you're lucky, they may have actually opened it and read it. They may have heard staff talking about these changes. They may have heard other clients talking about the changes. They maybe even attended one of the community forums that were presented by the New York City Department of Health. They may have also asked program staff or even their health home care manager, but not gotten a really sufficiently clear explanation of what's going on. And all this partial knowledge leads to a fair amount of anxiety about what's happening. So consumers, with all this anxiety and fear, first of all, they don't know or understand what's happening. They're noticing that it's taking longer to start up services. And just as an example, think about HCBS, right? They've had to complete assessments, 1 assessment, 2 assessments, which is pointing to bullet number 3, completing multiple assessments, and they're still not starting up services. So things are taking longer to get going. They're also they're concerned about what they think might happen. Will they be, for example, forced to switch providers? Will there be limits on how long they can be in services? Are they just concerned about having kind of too many people up in their business, right? All those assessments, a lot of information is being passed around. Not everyone likes that. So the program has kind of 4 basic responsibilities. The first is to clarify what is happening, right? You want to make sure that people replace their fantasy of what's happening with a clear sense of reality. And by clarifying information, this will partially reduce people's anxiety. It may not eliminate the anxiety, but it will reduce it a little bit. Clarifying what's happening is also a good opportunity to start bringing up utilization management issues, right, that there are possible limits to frequency and duration of services. It also means that it is essential to be clear about these limits and that they are being presented within a recovery framework, right? We're not limiting services and just letting people loose. We're trying to keep people connected and trying to help them improve their lives so that services are less needed. I also just want to mention that it's really important for us not to shift the blame on these changes over to the state. We should avoid having an us versus them mentality. When we say, well, I didn't want to do this, just what the state's making me do, that then makes you feel like you, the service provider, is out of control, they're out of control, and they're all kind of subject to the higher needs and desires of the state or the MCO. The reality is that we should frame this change as an opportunity to be putting into action best practice, which again is the recovery framework. So sometimes what we've found is that program directors are knowledgeable about what's happening, but frontline people are not as clear about what's going on. And I want to be very clear that everyone up and down the line needs to understand these changes. The counselors, frontline, whoever the recovery coaches, counselors, advocates, whatever they're called in your program, need to be understanding of this. Peer specialists need to understand. Directors, medical staff, front desk or billing people, health home staff, everybody's involved. And sometimes this is about responding to questions that a client might ask. Sometimes it's about correcting kind of erroneous statements that a client makes. So just as an example, maybe a client's in a medical appointment and as an aside says to the nurse, Medicaid's cutting me off soon. Well, that's not accurate. And so the medical staff that would be a great opportunity to explain what is happening. All right. So what I want to do first is look at that clarifying what is happening. And a lot of times when we explain what's happening, especially because this information is confusing, we resort to using descriptions that come from the state. And the problem with this is that the state's examples are intended for the most part to be for professionals, and they're very precise, which means they use a lot of detail and some jargon, and it's often additional information that is not really necessary for the end user. So when we're making these explanations, we want to use simple and clear language. And by simple, I mean kind of at a 9th grade reading level, just to give you a sense. So I'm going to give you some examples of these 6 questions, okay, using simple language. So the first question is, what's managed care? What is an MCO? So here's a sample written explanation. Managed care companies, what are called MCOs, or managed care organizations, are insurance companies that control which doctors, clinics, and other providers can offer care to someone in that MCO, whether or not they will pay for a specific service, like residential drug treatment or PROS, and how long they will keep paying for someone to get that service, especially if the person is not making progress, or if the person is making progress, right? So just as I wanted to just note, when I wrote this slide originally, the first sentence I had was, managed care is how New York State is paying for Medicaid for people with mental health and substance use disorders. But when I was reviewing the slides before this presentation, I realized that that's really not important to clients. They don't care about how New York State is paying or not paying. They just want to know that it happens. So I took that sentence out. So that's just an example of extraneous detail, trying to think about what the client feels is most important. That's the first one. And again, I've tested these are at 9th grade reading level. The next one, what is a health home? A health home is not a real place. It is a concept or an idea. And just notice, I use the word real as opposed to physical place. Again, trying to think about what's simple language. The goal of a health home is to organize people's care for their physical health, their substance use and mental health disorders, and even their social service needs, like housing, probation, or child welfare. Care managers are the people who work directly with clients to make sure all their needs are met and coordinated. And when you use words like coordinated, that's a kind of fuzzy term, right? Coordination means a lot of things in a lot of different settings. So you may want to give examples of what that means. They make follow-up phone calls. They check to make sure all the test results are in, right? They're coordinating. The third example, what is a health home care manager? The care manager is a person who works with you to organize your doctors and other healthcare providers, your psychiatrists and mental health or addiction services, and even your social services like probation or parole, HRA or HCBS. And these are, for those of you who are from upstate, HRA and HCBS are New York City agencies. Your care manager works with you to develop a plan of care, a service or a treatment plan that takes into consideration all your needs. Together, you'll figure out which services you need and the best place to get them. Then the care manager will work with all these service providers to make sure everyone's on the same page and paying attention to what you need and want. And notice here, when you talk about things like plan of care may seem obvious, but it's not necessarily. And so the best thing is to relate it back to a familiar term, like a service or a treatment plan. The next, what is a HARP? HARP is an abbreviation for Health and Recovery Plan. A HARP is a special insurance plan for people on Medicaid with substance use or mental health disorders who've used a lot of services in the past. And the meaning of a lot has been defined by New York State. I couldn't really figure out how to get past the threshold concept. Too complicated of a word. It is for people who are on Medicaid only. It is not for people who have Medicaid and Medicare or Medicaid and private insurance. In addition to their regular services, people in a HARP may be offered special services called HCBS. They also may be assigned an additional care manager at the MCO who helps them with their needs. Right? So you can see the kinds of words that were not in here, right? First of all, just as a really simple example, I didn't call it a specialty insurance plan. I called it a special, just simpler. What are HCBS? So HCBS, and here you can define it, stands for Home and Community-Based Services. HCBS are special services that some people in a HARP may be offered. HCBS services are designed to help people achieve recovery and stay out of hospitals or other institutions. HCBS services focus on 4 basic areas: employment, peer support, family support, and coping and everyday living skills. To get HCBS services, people need to participate in an assessment. Everyone in a HARP is required to do this. But just being eligible for HCBS doesn't mean you get these services automatically. A service has to be listed in your plan of care, your service or treatment plan, meaning that it makes sense for you and it is something that you are interested in receiving. Here's the big one, right? Will the MCO stop me from getting care? This is what people's basic concern is. So the first thing you have to say is MCOs are not trying to stop people from getting the care they need. MCOs are successful and make money if the people in their plan stay out of the hospital when it's not necessary, whenever possible. MCOs would prefer that all the people enrolled in their plan live in the community, in their own apartments, houses, or other living situations, rather than being in a hospital or another institution. To do that, they need to make sure that you get the right kind of care, the right amount of care, from the right providers. If an MCO cuts off your services and you end up in the hospital, the MCO has not succeeded and may end up losing money. MCOs partner with healthcare providers. They don't operate alone. They partner with healthcare providers to get you the services that you need to stay out of the hospital as much as possible. And to be clear, people think that MCOs make money by denying services. But if people who need services don't get them, chances are they're going to get sicker. And then they end up needing longer and more expensive hospital stays, which means that ultimately the MCOs actually lose money by denying services. And so this is a counter to the only way that they make money is by cutting me off. So just in terms of making this content understandable, I just divided this into two formats, right? Written versus verbal. And by written, I'm talking about things that are on paper or electronic or website stuff. So first of all, low literacy friendly. So we want to make sure to keep the reading level at a very simple level. This does not mean you are presuming your audience isn't smart, but it does acknowledge that when information is complicated, it helps to remove distractions and present the content as clearly and simply as possible. This is not an SAT reading test or, you know, college entrance exams or graduate school. This is really about getting across complicated concepts. The second thing is avoiding jargon, acronyms, and abbreviation. And the caveat is that if a long form of a term is never used, such as the words health and recovery plan or home and community-based services, it's fine to use words like HARP and HCBS. But whenever possible, try to avoid jargon. So some examples of jargon might be the HARP specialty product or separate product line, right? We don't want to use those words whenever possible. The third bullet point is opt for shorter words. And a good rule of thumb is just to look through your documents and look for all the words that are 3 syllables or more and think about whether there are 2 or 1 syllable words that are options. As the most basic example, think about utilize and use. Use the word use whenever possible. You talk about things. You don't need to converse or discuss. Talk is very simple. Finally, in written work, you're going to try to avoid dense text, big blocks of text with no white space. You want to have a lot of white space on your page. It just makes it easier to read through content. When you're sharing information verbally, you want to always be aware that people have potentially focus and concentration issues. So you're going to provide them with small chunks of information at a time. And you want to also get repeat backs to check for understanding. By repeat backs, what I do not mean is what we commonly do, which is I explain something, I say, okay, you got it, right? You see what I'm talking about? Because all you're going to do is nod and say yes. What you want to do instead is say, so can you repeat back to me what you think you heard me say so that I can see if we're on the same page? And that way you're going to really see if someone's understanding what you're talking about. Okay? The fact is this information is not intuitive, right? It's difficult to understand. And so you should expect that you're going to be explaining these concepts many times and in lots of different formats. You can't just expect that we can explain it once and you're good. Otherwise, MCTAC wouldn't exist, right? There's a lot of content that's very complicated here. Now, despite your best efforts to clarify, people are still going to be anxious and concerned, and it can sometimes be helpful to think about what are some of the underlying issues. So first, within the behavioral health population, we know that loss and abandonment is frequent, right? And now people are being told they need to be cut off from professionals that they trust and programs that they value, more loss, right? Many people are concerned about change. Stability means invulnerability, and when change comes, many people's experience is with change comes symptom flare-up, relapse, other problems. So they're not comfortable with that idea of change. Some people are not convinced of their own potential to achieve recovery, and therefore the idea of having a cutoff or having truncated services is extremely uncomfortable because they don't think they're ever going to get there, and then they feel like they're going to be cut off when they're not ready, and then to accomplish more than they are able to within much tighter time frames than they're accustomed to. So we just need to be aware that this is all happening. So in the beginning, I mentioned the word recovery, and I just want to stress that again. This model is predicated on the concept of recovery. This is the guiding paradigm. Everyone is capable of achieving recovery. By recovery, I do not mean symptom-free. What I mean by recovery is people who are, I'm looking at kind of SAMHSA definition of the 8 categories of wellness or recovery. People are living life. They're not being patients. They have hopes and they have dreams and purpose. They go through life's roller coaster and then they get help when needed, right? This means that people are not expected to stay in intensive treatment services forever. They're going to use the supports available to transition to less intense services. I'm hoping everyone can hear. We're getting a message that we keep cutting in and out of audio, and hopefully this is not happening to you. All right, keep going. All right. So just to say again, recovery is the structure within which all of utilization management should be occurring. Okay. So when you're working with clients along the continuum of services, you have lots of opportunities to talk about utilization management issues and themes, right? So, and these happen at different stages along the process. So when someone is in a pre-admission kind of phase, you may want to talk about why there are delays in services starting. You may talk about the need for additional assessments. You may be talking about what has happened so far so that people understand what's going on. Once you're at the admission stage, at this point, you should be explaining the concept of recovery pretty clearly. You'll want to talk about the expected frequency of services and the expected duration of services. But you don't talk about frequency and duration of services as a first step because you don't know the person. The frequency and duration of services has to be connected to the person's life history, their recovery capital. It has to be connected to the person's goals and objectives, where they are in terms of everything. So all of that is a single package. You're also going to want to talk at admission about the need for authorization and reauthorization, just so people understand what's going on. As they go through the treatment and service delivery process, you're going to want to make sure that you're reflecting on the gains that the person has made, and particularly how this is comparing to the original expectations. You're going to want to talk about any upcoming authorizations or reauthorizations and what the plan is if the person is denied. You may, if you're in a program that is particularly recovery-focused, such as a PROS program, you may want to talk about the documentation that how progress notes are being written, because you're going to see a greater focus now on deficits or barriers than you were before, in part because you're talking now about medical necessity, and that's part of where your reauthorization is going to come in. And you're also always should be thinking about preparation for discharge. When a person is at a pre-discharge stage, you're going to want to start talking about next steps, whether that's a step up or a step down, right? What are the other support resources? And you also want to make sure, particularly with a step down, that there's continued connection with health home or other resources. Okay. So the reality is that we do need to prepare our clients for understanding that services have a limit. The first step to this is explaining why we're doing this. And again, this is about recovery. If people are achieving recovery, they should have a less intense need for extensive services. Part of this also acknowledges that they may need a different level of care, however, if there are no results. If you're putting in, if somebody's coming in and receiving treatment regularly and is still not progressing, then it may indicate a need for a higher level of care. Again, services are the vehicle to achieve recovery, but not recovery itself. As part of this conversation, you're going to be talking about the client's recovery status and what they've accomplished to date, to date, and you're also going to talk about what the reauthorization process is like. And you should frame it as a conversation between the provider and the MCO, rather than the provider begs and pleads for reauthorization, the MCO decides whether or not to bestow that gift upon you. It's much more of a partnership. And you'll again reflect back on the original expectations regarding length of stay, but you can acknowledge that the MCOs have what's called a corridor for any kind of extra time or expense. There's some leniency about those, some flexibility with those expectations. Throughout this conversation is also a great opportunity for clients to reflect back on their original goals and to note where they are. And this is one of the reasons why having some sort of recovery measure process in place is so important. Now, I just want to make one quick mention that service limitations takes on a different meaning for people who are in drug treatment versus mental health. In my experience, most people who walk into a residential drug treatment center are asking about how many more days it is till they can leave that drug treatment center because they want to be over it. In mental health, people are much more likely to find themselves comfortable and to expect a long-term relationship. So this idea about preparing people for utilization management kinds of issues may be different depending on what setting you're working in. In terms of people who are approaching limits, so we know, for example, that in a clinic setting, there's these kind of soft or hard 30-visit limits. And there are also people who are overutilized, what we could consider overutilizers. So somebody, for example, who's seeing a therapist several times a week for talk therapy, and they've been doing this for, 7 years. That might be considered an overutilizer in the Medicaid managed care system. With those folks, you want to start exploring options for reducing services, perhaps cutting down to one clinic appointment a week, supplemented with community resources. You may be considering at this point the possible need for a higher level of care. If you're really requiring 3 visits a week, maybe the clinic setting is not the right setting. And you also want to be ensuring that other supports are in place, whether that's a RAP plan or a crisis plan, written relapse prevention plan, any kind of awareness of triggers or symptom flare-ups, community supports. And I want to just say a quick word about the written relapse prevention plan. Well, by that, I'm talking about literally a written plan. My experience in drug treatment has shown me that a lot of times people have a notion of what their relapse prevention plan is, and it's a little vague, and it usually says something like people, places, and things. And it doesn't get down to specifics, which people, which places, which things, which moods, which feelings, and having those kinds of written plans available that a client has with them all the time can be extremely supportive. So when it's time for reauthorization, in the best case scenario, the client and the provider agree on what should be the next step, right? So if you look at the green box, the green box, you see that the client says, I don't need any more care, and the provider says, I don't need any more care, which is great, right? You have a discharge plan, you start thinking about your step-down options, community supports, make sure you've got a good relapse prevention plan or RAP plan or crisis plan, good. If you're in the purple box, right, the client says, I really need more treatment. The provider says, you're right, you really do need more treatment. And now you're seeking reauthorization, right? You're going to look at medical necessity and documenting that. You're going to try to make sure that you have on hand any data that shows progress and outcomes still to be achieved. And you're going to reflect back the initial goals and objectives that the person had. However, the blue boxes are a little trickier. So in the blue box, in the darker blue, the upper left-hand one, you have the client says, I think I still need services, and the provider says, I think you're good to go. So at that point, what you want to do is look at the goals and accomplishments, and you want to talk, the provider should be talking with the client about what additional work they think needs to be done still. And I think it's quite fair to, if it seems unlikely that care will be denied, continued care will be denied, then the provider should say, I have some very real concerns that this will get approved. That's completely fair. There's the other side of this, the lighter blue box on the bottom right, in which the client says, I don't need any more care at all. The provider says, I still see some needs here. So again, you're going to reflect back on the goals and accomplishments and say, this is what I see. What do you see? What do we see as the additional? Let me tell you what I think the additional work needs to be done. How does this jive with your perceptions? All right. All right. So the yucky conversation, reauthorization is denied. So first you need to recognize that your client may be extremely anxious and confused. The discussion is you want to make sure it's clear what you are doing in response. You want to also start identifying very clearly what recovery progress has been made to date. And then you want to think through those next steps regarding community and other resources, any kind of relapse prevention planning, especially given the original goals and the work remaining. Okay. So when I'm talking about what the program provider is doing in response, I'm saying specifically any kind of challenges that the provider is making back to the MCO. So it's not like, oh, they said no, okay, that's it. But if the provider says, no, I'm concerned, I really think there's still continued need for services, then the provider would go back and challenge that denial, and that's something that you can be transparent about with the client, although you've got to be kind of measuring that against the person's anxiety level and how to balance those two pieces off without being overly protective within the recovery framework. All right, so preparing for discharge. Whoops, sorry. Preparing for discharge. So in the world of utilization management, discharge step down, step up is encouraged, right? So you don't just suddenly say, well, it looks like our time is up. You're really looking over time about preparing for this process. So again, and I think I said this before, but I'm just going to say it again, you're going to identify triggers or any early warning signs of symptoms flare up, and that's something you should do, you and the client do together. You're going to also talk about what makes people feel least vulnerable, right? There may be at this point special check-ins as discharge nears, particularly those who may be more vulnerable to an escalation of symptoms just prior to discharge. And again, recalling some of my drug treatment days, knowing that a lot of people will relapse just prior to completing a program because they are so ambivalent about going back to their families or being out on their own or not having structure. So you need to be aware of those kinds of vulnerabilities and be sure that you're talking about any kind of ambivalence, and also that you're checking in with people. When you're talking about appropriate step-down options, you should look at state plan services. So if you're at a PROS, you may move down to a clinic. You should also think about non-state funded options. So that could be self-help groups, that could be clubhouse or rehab models, that could be also natural community supports like church, community groups, recovery centers, whatever. So be broad in your thinking. And of course, if the person is going to be moving on to a stepped up service, you need to describe that also so the person knows what to anticipate. So just a note about stepping up services, utilization management does not only refer to limited services. If a person is not making progress despite ongoing services and treatment, a higher level of care may be appropriate. Maintenance and status quo are not the desired outcome. And I think that pretty much wraps up what I wanted to say. Before you go, we'd like you to take a minute to complete the survey in the comments section to the right, and there's those check-in questions again. We'd like to invite you to attend the next and final session, which will be on family engagement, which is next Tuesday. Again, there's no applied learning discussion on the 19th. And please email any questions, comments, or suggestions that you have to mctac.info@nyu.edu with the subject line Client Education Webinar, so we can be sure to respond to any questions you have. So again, take a few minutes to complete the follow-up survey located here. Your feedback is very important to us, so important that we thought we'd write it and say it. Again. Okay. And I think that's it.
Okay.
All right. So thank you all for attending. I hope this was helpful to you. And again, if you've got questions or thoughts, please share them. We're eager to hear.